Good afternoon. As you may know, this year Secours Expo has opened to an international dimension, and with speakers coming from various countries. So the second part of this roundtable will be in English with no translation except for questions at the end. A few words of introduction. As you know, today, or you may know, is marking sad anniversary, the 2 years of the official recognition by the World Health Organization of the pandemic. And 2 years later, if we look back, we have 6 million people who died around the world. And today, we're over 440 million COVID-19 confirmed cases worldwide up to this day. So, as we know, also the epidemic has put all health systems to the test. And 2 years after the start of this unprecedented crisis, while many countries are facing a drop of health staff, what lessons can be learned? How are we or aren't better prepared to face tomorrow's pandemics? And to debate over these questions, I'm happy to welcome Dr. Agnès Ricard-Ribon again. Hello, you're the head of the emergency department of Val d'Oise and also spokesperson for the French Society for Emergency Medicine.
Hello.
Dr. Abdo Khoury, good afternoon. You're the president of EUSEM, which is the European Society for Emergency Medicine. You're also consultant physician in the Department of Emergency Medicine and Critical Care in the University of Franche-Comté in France. Next to you, we have Professor Bernd Boetiger. Good afternoon. You're the head of the Department of Anesthesiology of Intensive Care Medicine at the University Hospital of Cologne in Germany. Thank you for coming from all this way. And next to you, we have Dr. Juan Manuel Gutierrez. Hello. You came from also far away from Colombia, and you're a consulting emergency physician. And we have also from Italy, Dr. Roberto Cosentini. Hello. You're the head of the emergency medicine unit at the Papa Giovanni XXIII Hospital Bergamo in Italy, and you're also a member of EUSEM. And I'm finishing the circle with Dr. Eric Revue. Hello. You're the head of emergency department and pre-hospital EMS SAMU of Paris, and also chair of pre-hospital section of EUSEM. Thank you to all be around with us. In the first part, you're all going to share your own experience from where you are since the beginning of the pandemic. And we'll have a little overview of the flaws of the European situation also in a transition part with you, Dr. Khoury. And the second part will be, you know, with what we've experienced. Are we ready or not? What should we do to face future pandemics of tomorrow? And I'll start with you, Dr. Cosentini, because of course we all remember what happened in Italy. Italy was hit hard, and Bergamo, your area in northern Italy, was one of the first European cities severely hit by the virus. How did your hospital in Bergamo face what happened, this tsunami?
Well, the story started the last week of February, as you all know. We saw the first patient with a strange pneumonia, who was already seen in another hospital 1 week before. And it was a very severe pneumonia, but the strange thing was he was not aware of the very bad situation of his lung. So he breathed normally. And this was very strange. And this was the first challenge we had in terms of professionals, because we faced a new disease. And this was the first difficulty we had, because we already saw the news from China about this terrible disease. And we saw that in China, they built thousands of new beds to face the surge of the pandemic. But I think we were not even psychologically prepared, because figures talk to the brain, but if you don't see the patients, you're not touched in your heart, so you don't start to think about solutions. And after the first patient, we set a unit of crisis in our hospital. We met twice a day, in the morning and in the afternoon, and we start to redeploy the whole hospital, starting from the emergency room. It was in a couple of days completely reorganized into 3 levels of intensity of care: low care, intermediate care for people who needed oxygen, and high care for people who needed ventilation, either non-invasive or invasive ventilation. And this started in the last week of February, after we saw dozens of patients with prolonged fever, and many of them were young people who, in general, do not seek help of the emergency room during the regular flu. So these were the days when we realized that the coronavirus was with us. And during the first week of March, the surge started to rise, and we saw an increasing number of patients with pneumonia, with this special kind of pneumonia. We saw the very first day of the pandemic. And together with the redeployment and reorganization of our emergency room, also the hospital behind us started to redeploy beds in order to make free places for new COVID incoming patients. And this was a very efficient solution, because the whole hospital reacted upon the emergency room flow, which is not the rule in the regular season. Because the wards have the patient, they have to care for elective patient, elective surgery, and so on. And this, I think, this was the solution who saved many lives and who avoided to be overwhelmed by the high surge. And the peak of our surge was about mid-March, when we saw in median 150 patients, COVID patients a day, with about 1/3 of them needing non-invasive or invasive ventilation. And this was for us the second challenge. The first one was professional, and this challenge was emotional, because we had the feeling of being in the center of an apocalypse, because we didn't have any medical solution for this new pneumonia. And also our fear was to fail as a health system, because the hospital was always increasing the number of beds to COVID patients. But you know that the length of the disease is long. But every day it was an increase of COVID patients coming to the emergency room. So the hospital rapidly filled up its capacity. When eventually the effect of the lockdown, the strict lockdown, we started after the end of the first week of March, started to have effect. So the patient, the curve of the patient went down, and also we could transfer our low care patients outside our hospital in order to be ready to accept new patients. And this saved many lives. And I think that our rapid reorganization, our flexibility, as you said in the first session, of this meeting, saved many lives and was the real core of our job. We are emergency physicians, so this is our job.
Dr. Caribon, of course, we were just across the border from Italy and sort of watching, but still from a distance, what was going on. And Dr. Cosentini mentioned this psychological dimension where as long as we haven't seen one patient, it's still kind of far. How did you, when you saw what was going on in Italy, did you think it's going to be us next? And did you start to think of how to prepare, or not until it happened in France?
We were prepared because we had the experience of Italy.
So you used that.
And we have the experience of Grand Est.
Yes.
So we made, with the French Society of Emergency Medicine, we made a webinar with our colleagues before having the wave in Paris. So we knew at this moment that Italy colleagues in Bergame had this experience, and so we are really afraid, but we had the information to anticipate, to prepare the system. And then after, can I have a question for you? Our difficulty was for the nurse and the physicians. We were very afraid about ethics limitation. And that was a real difficulty for us, because if we didn't have, in my department, there wasn't enough intensive care unit beds, and without the cooperation of Paris and after the other the transfer to the east or west, the real difficulty with our nurse or physician, how can we do if we have the patient and don't have the beds? And did you have these reflections, these difficulties in your service?
Yes, we had. I think we reacted as the poet Maya Angelou says. That is, you do what you can until you know better, and you do better. So this was our feeling. To see so many people suffering was very hard, but I think we had the feeling to be anyway useful for these people, and people trusted us in a different way when compared to the pre-COVID era, where patients continuously ask what is going on, what are you doing, what I have to, what time I will leave, what will happen if I go home before the test, lab test, and so on. So people were silent, they were completely faithful to us. And together with this, we, in order to match the need of ICU beds and high-level care to these patients, we first had the chance to transfer many patients outside our hospital, and in Germany many. Yeah, yeah. Yeah, I know. So we had a chance to provide other ICU beds we didn't could provide in our hospital. And secondly, we developed a chart, a score, a prognosis score for people needing an ICU bed, in order to prioritize ICU admission. And this was a shared decision between all the doctors and the nurses. So we always took this decision knowing that we were all on the same page. And I think this is very important for the single doctor who has to take this decision.
Excuse me, I also have a reflection here. We in Colombia, we deal with poor support of some oxygen network. We don't have that kind. I mean, the government buy many ventilators, but they forget how to connect the ventilator to our oxygen support. That happened to us. So we fight against the government because they come without these brilliant ideas without asking us. And they say, hey, stop it. So we finally decide that we have to open the emergency department outside the walls. And we take this, I know, like a decision with our guts, I don't know, and take hospitalization in home hospitalizations. And became to realize that we, the emergency physicians, have to go outside the walls and go to the home and even to the work, and have this kind of mini ICUs in home. So we have to deliver like a more open wide net. So we learn from you. So you.
What did you learn, doctor?
No.
From the European experience. What
I mean, we were very aware about all the experience they will publish. So we have a lot of people, we have a lot of patients, and we are overwhelming, we have overcrowding. So we just expect the first wave, like 3 months before you. And suddenly we awake one day and we have this amazing crowd of patients in the emergency door. So finally we decide, no, we cannot allow these people inside. We have to take it out and attend it at home. But that was a very courage decision, because we are not allowed ethical to go outside and practice at home.
How did you do that? I mean, you needed some equipment, some people also.
We have this rapid response team. It's like an ambulance with this condensation air supply, who can give supplies of oxygen to the patient in the home. And until we have another resource for oxygen, we just send them with that. And moderate risk and moderate patients can go outside of the hospital, and we take the few very ill patients inside.
If you look back 2 years behind, what would you say about the way your country faced the pandemic?
I don't know. I maybe we have a lot of mistakes, and we learn about them. So if I go back 3 years ago, we wasn't prepared to that. We were like, I don't know. And you know what? In my country, we have influenza and we have tuberculosis, and we are endemic to that kind of stuff, and we doesn't pay much attention to that. Now that we are learning about COVID, we are more aware of that.
Professor Botiger, yes, take a mic. How about your hospital in Cologne? What happened, and at the beginning of the pandemic and throughout the past 2 years? What adjustments also?
I mean, in the very first moments when we saw the pictures from China, our feeling was it will not hurt us.
I think everybody was agreeing on that.
As all the other pandemics before, or many of the other pandemics before. Then we were waking up when we have seen the pictures from Bergamo and all the transport by military of the dead people outside the city. And then we became really very afraid. And we have 100 ICU beds in my hospital, which is a hospital of 1,500 beds. It's the biggest in Cologne. Cologne is a city with 1 million inhabitants. And I'm responsible for 50 ICU beds. It's normally post-operative intensive care medicine because I'm an anesthesiologist. But when I have seen the pictures from Bergamo, I went to the board of directors of my hospital and said, we need to shut down elective surgery immediately because we will need the ICU beds. And then we had some discussion. They were thinking whether I'm a little bit too straight with this. But at the end, we reduced our overall usual surgical procedures by 30%. And we started with having one ICU empty of 15 beds. And we also built an additional ICU because we had a lot of anesthesiologists not working in the OR anymore because we had less surgical procedures. So we had anesthesiologists and anesthesia nurses. Mm-hmm. And in Germany, intensive care medicine is part of anesthesia. So they are all trained in this. And we opened an additional ICU. And we also thought, how can we double our ICU beds in the hospital? So the initial plan was maybe we need not 100, what we have for adults, but we need 200. So therefore we made a plan how we can get 200. So we ordered ventilators and we had the stuff. And at the end we had changed operation rooms into ICUs. But then, and we were about 3 or 4 weeks after Bergamo, the wave came to Germany. And fortunately, during the first wave, the German government was alerted, and they induced a total shutdown of the whole country, the hardest shutdown we had. So during the first wave, when the first ICU patients came, we were not in such a bad situation.
That's true.
We only had a very few ICU patients, and then the first wave was over. What I didn't knew during these days, I was really very afraid that we will probably have patients that we cannot treat because we don't have enough beds. What I didn't know during these days is that we know it now that Germany has a lot of ICU beds. So we have 3 times more ICU beds than Italy. We have 3 times more ICU beds or 2 times more than France. So with this regard, we have been in a very comfortable situation. And then after the first wave, we came back to a normal function of our hospital. Mm-hmm. And then same in the third wave, we rearranged the whole hospital, which was very stressful for the whole team. And the problem was during first, second, and maybe also third wave, we didn't have a vaccination. So we were all afraid that nurses, that doctors will die. We had seen the numbers from Italy, how many nurses and doctors died. And we had face masks only for 2 days or so. Then we ordered face masks in France, but the custom in France stopped our order of face masks, so France didn't allow export of face masks during these days. So, and at the end, I remember I just said it, during the first wave we also took patients from Italy and from Bergamo, In Germany, we had, I don't know, several, maybe 50 patients from northern Italy or so. In my hospital, 4. On my ICU, 2. And both were going back to Bergamo in a very good condition.
It wasn't too bad. Dr. Gutierrez, you had a few slides that you wanted to show us
yes.
on what happened in your country.
How COVID changed the use of emergency care. We all know that how overcrowding is part of emergency, and how we have some deals with it. There's a storm in Germany. We searched for strategies and solutions many times, how to deal with waiting times, ambulance diversion. But what was really that now that the demand for emergency care changed after pandemic. Yes, the care for chronic disease was damped. And yes, the stress for healthcare staff population increased due to COVID-19. But for the first time, we have the opportunity to change things. This is the first time that virtually can be accepted, even by doctors and by patients. And you know what? If I have this sentence, if you can organize the emergency department, you can organize the whole hospital. You know, the guy from emergency that are those who have the skills to deal with every kind of problem in the hospital, with all the respect of anesthesiologists. I mean.
The only not ED.
So this is the trend and how it compares in Colombia. We have this decrease of the demand, but the emergency for other things like influenza and tuberculosis became to rise. So we need to change our things. So this is now an emergency department that is outside the walls, go beyond waiting for what comes through the door of the ED, and it's more involved in community. So that's what we learned, that the emergency physicians has to go outside the walls and begin to be a part. This is Colombia. The green zones that you see is the most developed and populated parts, is where my emergency service network is. Mm-hmm. So this is a few pictures from the service. You see it empty, but it's not. It's just that the way we begin to make and organize the population. We have 4 waves, and we have now a continued demand for the ER. So now that we have the opportunity, we offer virtual care, and this allows to have these results. This is the results from June, November, and January. So in my network, if you see, our fatality rate keeps on a third of the rest of the country. Not because we are better than anything, just because we learn about to keep it safe. So this virtual thing allows to have this preventable demand. In January, we have 2,000 patients per day in virtuality. Now we have 10,000 patients per day in virtuality, and we are capable of redirect preventable demand of the emergency at 39%. So these virtual channels of emergency medical and care and guidance allows the doctor to guide an approach, to recognize and contain a risk, and to determine a patient if they really need to be at the emergency department or can be held in the home. So we have this Synchronous virtual care with 4 disciplines, with internal medicine, emergency medicine, pediatrics, and general medical care. So we are very concerned about the responsibility compared with the family. I mean, we have to engage patient care with family, so we are not alone, because everybody expects that the doctor knows everything, and we don't. So have this rapid response team and detected the risk. So we are achieved to have home hospitalization, and this liberate beds in the hospital. So we now have a better flow of patients to dispose beds, resources, time, environment, and we redesigned the emergency route. We take some examples for the first view concept that you all know about how to redirect facilities and improve our attending threats and the patient flow, and know how to queuing system, and know how to deal with the very good route. We are not the best, but we are going good. So we have this basic emergency care center. We potentialize it and make some frame time in the basic emergency level to redirectional the COVID patient, the normal patient, and all the biohazard biological risk. So now we can have this like a menu. When you are in a pizzeria, you cannot beat another like in a hamburgers, you know? So if you are in emergency basic level, you have to deal with this menu in imagines and laboratories, and you cannot allow to ask for any else. So this makes us that the laboratory and the focus goes in less than an hour to have the results of what we really need. And we focus the emergency physician, the internal medicine, the pediatrics, and what the patient really needs. Focus and solve the emergency, eliminate the risk, and minimize the complication. This is not in the pre-grade. I mean, this is not taught in the university. We learn it in the road. So now we are more aware to be practical and have especially to what the patient really expects to be resolved in the emergency. And this allows to begin to speak the same language, you know, because that's a problem. Everybody wants to speak his language. I mean, the anesthesiologists, pediatrics, internal medicine, emergency medicine. This allows to everybody speak the same language and to focus on what the really problem is. So we have to deal with the same resources every time with more patients. And the emergency physician is this guy who has the skills to rule the whole department. So we improve these skills to be the guy who really has the governance in the emergency department. And we also has improved these exit routes against with service agreement and strategies alliance. So we can achieve a continued care route. We can a better opportunity for allocation in hospital beds and opportunity for image support. And going with this, we also changed some paradigms. You know, the emergency radiologist is part of our team now. Before it was in the basement, lock about. I mean, you know, the radiologists were in other space and time and whatever. Now he's part of the team in our emergency department, and the focus is part of what we really need. We also redesigns the time, so we have more time to do better practice. And you know what finally? That this gives us less burnout, better environment, the leadership from emergency physicians. She now can do a better accompaniment for the all general doctors, and to guide them to the really approach that we need. So this was what the pandemic gave us from lessons, and that's what I want to show you. This is Colombia. This is just you can see the sunset. Have our flag, my flag in the sunset, and thank you.
Thank you, Dr. Gutierrez. Interesting. So some positive issues came out from the bad time. Dr. Revu, when you saw this presentation, what do you think of all the adjustments on the ED? Are we facing the same challenges in France?
I think I agree with the fact that due to the very strong coordination between countries and emergency physicians that know each other, it will be the first step to have a really partnership and exchange of your experience. I agree with Dr. Bedigan. We have 2 weeks later from Italy. So that was really important. We have the same organization of healthcare in France than in Italy. So it was really the same patient that we need to have, that we'll have. So the very good experience of and bad experience, good and bad experience of what you have, it came just 2 weeks later. And I agree with Dr. Bediger that we have to organize our hospital just before the wave were coming. Because I agree, when we had the email from in December and from China, it was really far away. Very far. You cannot come to really. It's not. It's in China. It doesn't matter. No, but in Italy, it's quite different, and in the north of France, that was the same. So the experience of you have. The main thing we have from Latin American countries is resources, lack of resources, organization, beds, of course, ICU beds, and when we can compare with similar organization, was really a good way to get prepared for that. That was really the most positive points. And then after, thanks to webinar, we have during the COVID situation, pandemic, exchanges. Yes, we have always to update, not always the number of patients we had, but more how you deal with this organization. Because one of the things you didn't say, it's one time in Bergame, they have 2 patients in the same time, just 1 ventilator, and was really scaring for us because you have to deal. I have a 48 patient and a 60-age-old patient. We have to choose, and that's the thing we didn't want to have. So that's why we try to organize and to get prepared. It was not easy to do that.
Interesting. So the webinar was it? International
webinar,
Europe.
And Europe mainly, China, Turkish, US. We have a lot of communication with all countries. That was really a first step to help us.
Dr. Abdo-Kouri, we can have a little section with you to have an overview on the situation in Europe, because we don't have this vision, so we just to understand how Europe as a structure, European Union faced the pandemic, what happened, and you'll have some slides as well, and you'll tell us about the flaws as well of
I don't have the pretension to speak about how Europe is organized. Europe is very complex, and even Europeans that deals with Europe on an everyday basis, they do not know how it works. But anyway, thank you for the invitation, and thanks, Eric, for having given us the opportunity to speak in the National Congress, to have an international view, a European view. It's always good to have this eye opened on the world. I want to thank my teams in SAMU for the extremely hard work they've done, like everywhere. Not only in Besançon, but in Paris also, but in all the countries. All healthcare professionals were really, really fantastic. And they've got a huge job. And Agnès have spoken about it before. And if you want to speak about the European response, I think that Professor Bottiger have summed it up. He just turned back to me and said, you in France, you didn't give us masks. And I think we can summarize this by this sentence. But I will go a bit more far from this. As we all said that when it comes to China, when it started in China, none of us have thought it will happen into Europe, because we've had already past pandemics, or let's say more small endemics, and we didn't say, okay, it will not happen, and it will end up like every time. But it started in Bergamo, and we were all afraid of that. And immediately, almost immediately, within days from Bergamo, and I'm not sure that of the date, Roberto, was it February 2021, or it was a bit before? Yeah.
Lodi.
The very first town was Lodi in the 20th of February.
Yeah, because I live on the border with Switzerland, and my region is very industrial and very macrotechnics. And there are lots of connections between Franche-Comté, Switzerland, and the region of Milan, Bergamo, all this, northern Italy. And we got the first patients coming almost the same time from Bergamo, 1 or 2 patients. But we got a huge cluster nearby Besançon in Mulhouse, which was a church, a gathering of worshippers that were there and believers, and it was a huge cluster. And this cluster have impacted massively the east of France, but also part of Germany, and part of Italy, and part of Switzerland. It was really another cluster that when Bergamo was facing, we were facing immediately. That's why we prepared a bit quicker than some others in Europe, let's say. But I go much further, and this is Germany. Of course, we didn't give you masks, but Germany, immediately when Bergamo started, have closed its border, or part of its border, the eastern border, the south borders, Italy, Czech, and others. They didn't close with France immediately because there were no threat at that time. But this is something that, when we go, the European Commission wasn't happy with that, but this is what happened in Europe. And I'm talking about Germany because it was in center, because it was in Italy, but other countries have done the same. France have closed borders, Czech have closed borders, Italy have closed borders after, everyone have closed borders, and everyone have forgotten they were European. We've forgotten that we have Schengen and we have open space, and every one of us have established again our borders. And this is the first thing that happened in Europe. When we were supposed to respond as a community, as a whole community, we responded individually by every country, and even sometimes by every region. I don't know the case in Germany, it's lenders, so they are a bit separated. And just they said they were not aware of the capacity of their ICU beds in Germany, but although they were the biggest in Europe, because of maybe of these lenders, because they don't talk to each other. I don't know, I'm talking now just prudently. In Italy, it's the same also between the north and the south. In Belgium, even in Brussels is separated in two parts, one Flemish and one French or Francophone. It's even this, and we saw it in the attacks on Belgium, in the terrorist attacks. There were miscommunication between the two parts. So how do you want to construct Europe when you are even in the same country, you're not talking to each other and not aware what's happening with your neighbor? And so every one of us have prepared differently. We didn't speak about how to prepare altogether. And it comes to these PPEs, these masks. All of us, let's say, we were supposed to have equipment, to have collections, to have masks, and to have strategic stocks on a national level, but also on European level. It turned out, unfortunately, that none of these stocks were renewed. Some of them were already, let's say, were destroyed. Others weren't renewed because we just said, we don't need to put lots of equipment like that. We just fly 2-3 jumbo jets to China, and we got whatever we want in almost 24 hours. It was one of the mistakes. So we got our equipment, we closed our border, and we didn't share our equipment. Germany asked us for masks, we kept them for us. We didn't give them. And maybe Italy have asked for ventilators to Germany, and Germany have kept them for them, you know. And then what we've done at the first moment, the first hours, in Bergamo, people were dying. They were not having enough ventilators, enough beds. And we were not able to transfer people from Bergamo to Germany or to France. I'm talking about the first days. And after this sedation period, we just woke up. If you see here, our preparedness is not that good in Europe. When we go to the European countries, this is ICU beds we are talking, and you see Germany have twice the capacity of beds, Germany and Austria, twice the capacity of beds like Belgium or France. And we are on the top of the European countries. If you go down on the other European countries, you can see that others have less and less beds. So we're not able to build a European healthcare system all over Europe saying, look, we need 33 beds per 100,000 inhabitants all over Europe. In Germany, it's 33 beds per 100,000. In France, it was 15, 18, others 10. So we don't have standards. We have them, but we don't apply them. So it's also a big problem for us. And of course, for other, also for regular beds, also, we're not aligned at all. And we cooperate on a daily basis. Germany and Italy cooperate on a daily basis. We and Germany cooperate on a daily basis. And these are some slides. This is the regions of Grand Est, the eastern part where, at the left side of the slide. This is the eastern part where we were hit with the cluster. Usually on a daily basis, they cooperate with the border with Germany, with the landers. We know each other. All of us here, we know each other. We are in the same research networks, medical networks. We write papers in the medical press together, so we know each other, and on a daily basis we collaborate. We transfer patients without any problem from France to Germany, a bit less from Germany to France because they have much bigger offer. We transfer patients from France to Switzerland on a daily basis. There's no issue with this. But this day, everything has stopped, and everything should have been centralized by Paris, Berlin, and Rome, which is not good. We know how to work in networks in our borders, and these borders started to exist and started to stop us from collaborating. Fortunately, it took some days, and then we very quickly opened up the borders among ourselves. The first waves, we've done that. And when we got more and more COVID patients all over Europe, once again, the borders have closed again, and we have to centralize all our transfers. So when I have to transfer someone from Strasbourg to Freiburg, which is like 50 kilometers away, I have to call Paris, which have to call Berlin, and Berlin have to say okay or not. Although there were places. And for Switzerland, it was the same and everything.
So did you have to go through this process? Or?
We had to go through this process, unfortunately, although on daily basis, if we scientists, if we doctors, if we healthcare professionals have worked all together like on everyday basis, the crisis would have been solved much easier. So, is there a Euro response? Yes, of course, all these big heads of this of Europe have just met in summits, virtual summits, everything. So yes, we should have a European response, and started to put the response, which should have been already put before, but unfortunately not. And especially in the lockdown, every country still has its own strategy. And we see this paper of 5 countries describing the 5 strategies. When you have a Boris Johnson, which is main concern, how to open up the bars and sending people to drink beer, it was his main concern. When you see the Swiss, the main concern is to make the economy works and the banks works, and they didn't want to shut down because of the economy. When you see Sweden, they said, okay, we're gonna do a herd immunity because we are really, let's say, we care about the freedom of everyone, and we will not lock down people, and we just will rely on their responsibility. We see on all of these strategies, at one point didn't work. So we weren't uniform in our response, and that's also caused us a big harm. And then, petit à petit, let's say in French, and slowly, we started to put a strategy in Europe, and we started, after this big phase of sedation and the massive lockdown we've got in Europe, we started to put strategies, we started to discuss, and we started to say, yes, we need testing very quickly, we need vaccines very quickly, and we need to really discuss all together to have a big force to buy vaccines, to buy tests, to manufacture things, ventilators and others. And we started to do that. But it was a bit late, unfortunately. And about the vaccines, so they will do a transition with the vaccines. We said, okay, we're going to develop our own vaccines. But once again, GSK in UK have developed their own vaccines without really, not GSK, sorry, AstraZeneca. It was a German-UK cooperation, but it wasn't a European cooperation. In France, we were hoping to have the Sanofi vaccine, which never arrived. Yeah. And let's say that, fortunately, our leaders have talked together on European level to say we're going to order vaccine from Pfizer and from Moderna, and that's why helped us to have vaccines. Otherwise, we in France maybe or in other countries, we were still waiting for vaccines today. Our national industry to work for vaccines. And we see we've just have a centralized approach to buy vaccines, all of us, all over Europe.
So there was a progress then with the vaccine step.
A huge progress. Yeah. But not only, unfortunately, we've got this platform, but even this, every country still was purchasing her own stock on top of all this. So France was also aiming to have their own stocks. Germany, Italy, every one of us were also still on buying more and more vaccines on national levels. And we didn't have any strategy of vaccinating. Who should we vaccinate? How should we start? While in UK, they had 4 million in December. We're still with the first one, the first lady. Forgot her name, Germaine. Forgot her name.
No, with the name.
90 years old.
Morissette,
exactly. It was really emblematic, and all the humorists started to write cartoons and everything on Morissette. 4 million in UK, Morissette in France. So it was not acceptable. Germany was 1.5 million or something like this. So you see, the strategy wasn't working. Of course, we as Europe have a responsibility toward the world also, toward the third world countries or the countries that do not have the same, let's say, capacities as we have. And we donated lots of vaccines on the COVAX platform, the COVAX from WHO platform. We've done that, but we didn't do enough, not only Europe, but also the United States and others. We didn't do enough because what's the aim of vaccinating only European people and do not vaccinate the whole world? So we have to live and shut down Europe or in lockdown Europe. It's not that good. And I think that we could have produced more vaccines, and instead of putting lots of money in the economy, in the shutdown of the economy, we've put trillions and trillions of euros and dollars in this economy. We should maybe have paid more vaccines to distribute all over the world, and we could have opened up the world much easier and much quicker. And last but not least, did we learn the messages? I guess that yes, we had messages, we learned the lesson, and we started to think on of the future. And recently, in this crisis, have revealed that we need a coordination on the EU level. And you know, all of us, we spoke about this in different countries, in different webinars, in different occasions. We need a coordination on the EU level, and the gaps in foresighting the demand and supply. We do not have any more industry in Europe, more or less. All our industry were tributary for China, from maybe South America, from Africa. We do not have any big industries on our territory, in European territory. But also, we should be more prepared and have more response tools on the European level and not only on the national levels. So, HERA was created with the European Health Emergency Preparedness and Response Authority. It was created in last September, was a State of the Union big one, that's saying, okay, we're going to have an agency to respond for this health crisis. Why I'm saying this, it's a bit too late, of course, but it will be for the future. We already have a mechanism of civil security. If you have an earthquake in Bulgaria or in Italy tomorrow, we have a huge European response that will take place in 24 hours. We know how to deal with this. Civil security in Europe is very well organized. But health issues in Europe are not organized simply for one important thing, that health care issues are related to the nations and to the countries and not on the European levels. It's like the defense, also the military, the Ministry of Defense and the defense of Europe is also on the national level. And that's why we are facing now issues with Ukraine and others. But that's why we should really go up from the national levels and to build the real European healthcare response. I hope that the HERA, that have a budget today, which is quite with few billions. I hope that this budget will stay for HERA and they will not forget everything after the COVID and say, okay, we don't need it anymore, and it's forgotten.
So there is hope with this new new structure, HERA.
We hope that. We hope that. It's already ready. They are putting the mechanism how to intervene in the future. It's really a better EU response, which will be cross-border, and not only for national, but cross-borders. And this is something very important. And finally, if you want to have a bit more on these discussions, we'll invite you to the Open Conference in Berlin, to be in Berlin this year. And we're going to discuss lots about COVID, about the experiences that we've learned, but not only. Maybe we're going to, unfortunately, start to speak again about the war and the response during the wars. Unfortunately, this is actually the topic.
Thank you very much, Dr. Khoury. That was very interesting to get this overview and take a bit distance and try to see how what happened here. Dr. Costantini, is this one of the challenge to be able to work more closely between countries? Did you feel that way? Did you feel isolated then? And do you feel we need to?
Well, I think HERA is one of the big answer to the challenge. I think the pandemic gave to each nation the tools to see where there is the lack of resources or organization, and to work about to answer in future challenges, in future pandemics.
What would be your priorities?
Our priorities, our failure during the first wave was outside the hospital. I think the hospital responded very well, since we were not prepared and we had a huge wave, unexpected huge wave. And also the EMS responded very well, the SAMU. The problem was with the general practitioners, whose system almost completely collapsed, especially because most of them, doctors and nurses, got sick. So the people didn't have any responder to their request. So during the first wave, for instance, we in 2 months in our hospital, which is 1,000-bed hospital, we saw in our emergency room 2,000 COVID patients in 2 months. We were able to discharge 50% of patients. That is, 50% of patients who seek attention in our emergency room did not need hospital admission. We learned this lesson. And the system of the general practitioners outside the hospital was reorganized so that during the second and the third wave, people were seen at home, just as in Colombia. They were monitored with the pulse oximeter, saturation, and they only went to the emergency room when they desaturated, so when they needed hospital admission. So during the second and third wave, we admitted more than 80% of patients who seek attention in our emergency room. So we learned the lesson. And we learned that this is our weak part of our health system, and this is to be reorganized in future. And this has emerged during the last wave, when we not only had the COVID wave, the COVID surge, but also we had a surge of all the rest of patients who had no COVID and who found a smaller emergency room for them and a smaller hospital for them. And this is the problem we have to solve for the future. We have, fortunately, the European funds, and we have to invest. We know, as you said before, we know the solution. We have the proposal. We have to invest in all that.
Dr. Ricard-Ribon, the fact that we saw, the number of emergency department patients fall strongly, especially during lockdowns, it shows that EDs are probably overcrowded on a general basis. What should be done then? I think it's probably a concern for you as well.
The fantastic cooperation between emergency and GPs was good, and we need to continue this cooperation. Okay. In the first wave, most of patients stay at home and at visio, teleconsult. But after, they need to see a doctor, and we have COVID in les maires, comment ça s'appelle les maires? Les municipalities.
Municipalities, yes.
But we have the same thing that you. There's COVID people and non-COVID people, and actually we have a big problem with oncology, because most of patients didn't went to the hospital to diagnose.
Of course.
And the hospital was too little for them. It's the same diagnostic. And we have to optimize all the filières de soins, the
departments, to make sure that
the pass
yes.
For these specialities. And I have a question for you, Columbia. When you say that the physician goes out of the hospital walls to treat at home, did you have cooperation with GPs, a general practitioner, or all the general practitioners didn't went at home? Because we have patients with oxygen at home. They leave the hospital earlier to leave beds, but it was the general practitioner who go and take the relay at home. Do you have this cooperation or not?
We have the general doctor who is allowed to have like 15 patients, and 7 general doctors are with 1 emergency doctor. So we have this like a pyramid. So everybody has not only the pulse oximeters, a call. So they have to report every day. When the results are away from what we expect, we activate the rapid response team, and they go and see what happened. the doctor is able to deal more of the complication. If it's something real sick, the emergency physicians go to there, and we are able to maintain the people outside the emergency. And it works pretty hard because, remember, we have not the same resources as France or Germany. So we have to deal with what we have. So this worked pretty well. I mean,
we have the same system. So it's GPs and the SAMU, which has the emergency physician who can be called by the GPs if the patient was going down. So it's interesting to see that it works.
Yeah, it works.
Yeah.
And you know, it contains like 40% of the preventable demand to emergency. So it was very interesting because we liberate beds in the ICUs, so we can contain this moderate risk at home. It was afraid, but we have to engage the family and commitment, because you know the family are demanding and they say, I need to be in a hospital, and say, no, wait, we can wait. So that's part of a change of culture. So.
A question to one of you. Did you face also a big, strong fight with anti-vax people in your own country, like we had in France?
Yeah.
Yes.
Yeah. We had a big fight. This is the gray. Well, actually, the black aspect, the black face of social media. The white face was where the webinar we had during the first wave that allowed us to work together and to spread information. That was very
useful.
Very useful also for us. We didn't feel alone. You asked me before. We struggled with anti-vax also because they take a big part of the voices on the net, because they tell stories, and people are very attracted by stories. A patient who didn't get vaccination and goes well, or another who got vaccination and got terribly sick. And also we had another gray zone of non-vaccinated people who discovered during this very last wave, who are the very elderly people who stay at home because they're bedridden, and the family think they're not at risk of COVID. But however, they see people, they see the families, they see the people who clean the house, they go outside, and they inevitably get COVID and get very sick because they're not vaccinated, and they had to be admitted. And this is a very big challenge, even though we are in Italy one of the most vaccinated country in Europe. We come after, I think, Spain and Portugal.
Better than in France.
Yeah.
Dr. Gutierrez?
Oh, yeah. And the worst part was these few doctors who are anti-vaccine. I mean, I don't know what happened with them, but it was very, very worse, frustrated, yeah. Bad thing.
And Professor Bottiger, did you also have?
Yeah, we had also these problems, not at the beginning, but later on, in particular in the former east parts of Germany, where we also have a lot of right-wing people, and they are in major parts against vaccination. In my hospital and in my city, we are on the top of Germany. We have more than 80%. We cannot catch the numbers of Italy or Spain because you have been really shocked in the first wave, so therefore you have a high level of motivation. But in my city, we also have high levels, and also in my hospital. So I have 200 doctors in my department, and only one is not vaccinated because she's afraid of getting pregnant and all these things. But we have 98% vaccination in our hospital, and this is all over the western parts of Germany from, I think, March 25 on or so. I'm not sure about the date. You are not allowed to work in the hospital in Germany anymore, and I think in Italy it's already since months or so, if you are not vaccinated. And I think that's the right way to go.
A question also towards the end, and then we'll take a few minutes for some questions with the public. We understand that collaboration is essential worldwide, I would say, among physicians. Dr. Revue, who should coordinate? Is it the World Health Organization? Is it a society like EUSEM? How do you go worldwide?
I think that EUSEM will have the role of scientific level for that, and because we have we know each other, that's all the friends are, but the experts are also scientific who were just on the front line. So we need to implement a program, very close collaboration together. But of course, we need to have a political aspect of close coordination, because if you want to have a fast and rapid response, if you want to have a colleague from Italy, from Colombia, in Germany, they need to have our help. We need to have an active program with pre-plan, how we can react very, very soon and very quick.
And who should write down the plan?
I think it's have to be a European project with the political coordination. That's for us in the only way.
What do you do with Colombia? He's not in Europe.
No. I take the example because it happened for many countries that if they call us, we have a special response team to work everywhere, not only in Europe. And we usually, when the earthquake everywhere, we have this kind of response team here. They have a lot, so we know how to do that. But the thing is, mostly the main point is political way. When you want to send a team, you need to have the agreement of the country first, if you want to say, because that means that okay, you mean that we are not capable to do that. So that's the thing, is we need to have an organization for that.
Dr. Khoury.
I guess Eric is right, and the scientific society here is EUSEM or ESAIC or ESIC or others. We provide the experts. We are on the ground. We are the clinicians. We can give the guidance, but it's the politics who has to put this guidance into music, and they have to do it because they have to balance the healthcare issues, the economical issues, other issues. So it's not easy. In Europe, European countries are strong. European Commission is strong. While in the rest of the world, WHO is strong, let's say. It's much more present all over the world than in Europe. But now, things with the COVID, we just see that we have much more collaboration with WHO in general and WHO Europe. So things are going into the right direction, let's say. But we should, in Europe once again, has the healthcare issues on top of the nations. Otherwise, we will not be able to deal with such kind of emergencies or such kind of pandemics in the near future.
Okay, thank you very much to all of you. We'll have a few questions, a few minutes for questions if we have some from the public.
So thank you for this debate. Let me introduce myself. I'm Jean-François Gillard, and I'm a head operation in health administration in Belgium. And I'm responsible for operational deployment of emergency medical aid. And so let me begin with a positive story. And I really, in the name of the people of Belgium and my health administration, really thank our friend neighbors of Germany, because during second wave, they received 29 patients from Belgium. And without that, we would have been up above our maximal capacity, and we would have been confronted with ethical, really difficult questions about choice of patients. And we've helped a little bit France also with transfer of limited number of patients from north region of France. And so it works. But my analysis is, I'm really disappointed about my politics. I'm a little bit disgusted, as this is a personal meeting that doesn't represent my administration point of view. Should we, our governments in Belgium could have done more things to give means to hospitals to face the crisis, to reduce the number of patients with strong measures about confinement, isolation, and so on. And so, I think really structural system has failed, but medical personnel have prevailed with involvement, bravery, responsibility, ethic, deontology. That is the face. But you cannot build a health politic at long term only on goodwill of people. That cannot work.
Professor Bottiger, you want to?
Yeah, thank you very much. I would like to say three things, and I very appreciate your comment because it's more than true, also for Germany and for many other countries. In Germany, as you said, we have 16 different regions, 16 different Bundesländer. All have their own government and all did their own things. So that was really crazy, and they made a lot of mistakes. And the political responsiveness was not. I mean, they did so many mistakes and nothing happened. I fully agree. Second thing, I didn't know that, but I learned during the pandemic that WHO is not financed by all the nations, but also by private, by Bill Gates, and also by others. That's crazy. We need to have a World Health Organization that is financed by the nations and not by private any other interests. That should be forbidden. And, sorry, you mentioned at the beginning that 6 million people have died during the pandemics due to COVID-19. On the way in the train from Cologne to Paris this morning, I have received an information, a publication in The Lancet from today or yesterday, that scientists have calculated 18 million people have died, so 3 times more than we knew from before. They just analyzed the regular death rates over the last, 7 or 10 years and compared them during the pandemic. And the most affected regions of the world were South America, Sub-Sahara Africa, and Middle and East Europe. 18 million, not 6 million. Huge. Publication from The Lancet from today.
Dr. Ricard Ribon, with the politic question and
I completely agree with your comments. We need health policy in all countries, but a cooperation between all countries about pandemic. And I don't know how to do that. As a doctor, I know now that we need to go and speak to our politics. We don't have this culture. We stay in our hospital and we think that politics understand when we talk to them. They don't understand anything if you don't go and explain to them. And you need to take time for that. We don't have time because we are also always busy with our patients. But it's really important to go and tell us and explain and invite them to see how works in hospital, how we can work all together. Because with this pandemic, but before the pandemic, the emergency department crisis before, I understand that they don't understand anything about the hospital
challenges and what's at stake.
So we need to talk to our politics.
But you know what? We need to make that discourse very attractive to them. I think that if we can in some way teach them how to save money, that will make us to listen us. I mean, yeah, could be part of the discourse. You know, you can save money, you can save your images. You know, I don't know.
Yes, but at one moment things are crazy. At one moment, it was so difficult about political question to have strong sanitary measures in Belgium Political government have asked to my service, okay, prepare a plan if there is an explosion of contamination, if we open all now, because it's too difficult, it's too tight to maintain, and okay, let's prepare a plan, a big plan, if we have a explosion of rate of contamination, because we will open all now without sense with the numbers of contaminations and the progression of the pandemic. Really, that's crazy. And what about the masks? It was really a funny story. Yes, we had masks from H1N1, but it was in a warehouse with humidity and so on, and so we must just scratch them. But we have not replaced these masks, because Ministry of Health would have been just discussed with parliamentary, why have you bought masks for something hypothetical? But we know now we would have used this mask, and the communication of the government was depending on the level of disponibility, of availability of masks. At one moment we haven't masked, and so government said it's not so necessary to wear a mask, because we are not able to provide you masks. And when we had, okay, you must wear masks, we have masks now, you must wear it. That's just full crazy. And last point, so funny, the story of the mask in Belgium was so nonsense, and Europe has asked to Belgium to manage and handle the strategic stock for Europe. It's just...
I mean, thinking about any future pandemics, I'm not so optimistic about the better reaction of our politicians and of our people that vote for the politicians. And in my mind, I'm always comparing this pandemic. We have 18 million deaths probably, but a much bigger pandemic will be the climate change and global heating. And we are facing the same group dynamics. We have the same decisions, wrong decisions by politicians. We have the same behavior in our population. They say no vaccination, no measures against heating of the world. So the next pandemic is already coming. We know this since 50 years, and nothing is happening.
Migration is one of these. And migration is one of this future pandemic, which ongoing pandemic now of climate change.
Yeah,
it's a huge thing.
We know it, and we are not acting.
Dr. Cosentini, you wanted to say something?
Maybe the HERA or the sovereign national coordination could be the response to this problem in the future. We hope.
Okay, well, thank you very much to all of you for sharing your views and your time.